good afternoon. I am Dr. Usman Naeem, a gastroenterologist, and today's podcast is very important. We are going to discuss about the future of hepatology in Pakistan with the insights from Pakistan Society of Hepatology. We have renowned two guests with us, Professor Graham Foster, he is a gastroenterologist from England, and Dr. Asad Ali Chaudhry. He is the president of Pakistan Society of Hepatology. Welcome, sir. I have a question. You discussed last day the WHO goals 2030 to eliminate the hepatitis from the worldwide. How realistic it is?
I think we've got to make it realistic. There's no question that it can be done. Egypt has already eliminated hepatitis C. And in Pakistan, we know the drugs we have available work effectively. We know that people want to take the drugs. We know that if we treat very large numbers of people, we can stop reinfection. So I think it is realistic, but it will take a step up from where we are today. We need to stop doing little piecemeal clearance programs and have a national program, because only if we can get everyone found, everyone treated, will we stop new infections and halt this virus. The gains to Pakistan, if we can achieve this, will be enormous. We will see far fewer people dying of liver cancer. We will see far fewer people dying of cirrhosis. And what is new information is we've been looking at work productivity. And people with hepatitis C, they're tired. They don't work as well. Mostly they're unemployed. So if we can treat everyone with hepatitis C, we put 10 million healthy people back into Pakistan, and that's going to have a big impact. So we have to do this. Don't say we can't do this. Say, how do we do this?
How to do. So this is doable, but we need to change the strategy in some way?
We need a global strategy devoted to clearing hepatitis C in Pakistan. You can do this. You guys are good at doing these things. You had a national strategy for COVID. You controlled COVID. With a national strategy for hepatitis C, you can do it. But it needs political will. And if we have the political will, this virus will go away.
So it is doable, and we need a strategy.
Absolutely.
Thank you. So the next question is from President. How do you see the hepatology is it challenging in Pakistan?
Yes or no, but I think what I've always advocated, that we have to go to basics. We are a country fraught with a lot of problems, and most of the problems can be handled at the basic level. If we talk about hepatitis, viral hepatitis, what we need, clean drinking water, what we need, good hygiene. And coming to hepatitis B and C, which are blood-borne infections, we just need to be careful how we do not get it from the needles. And till today, we are one of those countries with the highest injection rate per person per year. So the practices need to change. People have to be more aware what causes hepatitis, and at the same time, because especially talking about hepatitis B and C, they do not cause symptoms in the initial stages, we have to test and treat. So everybody, we need a universal screening program, and for all those who are tested, found positive, they should be linked to treatment. And last but not the least, do not forget about the vaccination of hepatitis B in Pakistan.
So hepatology in Pakistan is more of the viral hepatitis?
Not at all. There are lots of other things when we talk about...
the major chunk of the patient comes with the viral hepatitis.
I still feel we are struggling with chronic viral hepatitis C. We have the highest number of patients in the world as far as hepatitis C is concerned. The thing is, this is treatable, this is doable, this can be eliminated, as Graham mentioned in his comments. And now we have one of the highest burden of what you call fatty liver disease, which is now the metabolic dysfunction associated liver disease. And this is another challenge. Obesity, we all know our eating habits, the culture, so that's another challenge. And drug-induced liver injury, I still feel it goes on. There's no check on people themselves procuring drugs.
Self-medication.
Self-medication. Hakim medication, unregistered medicines. There are lots of things. You name it, we have it. But if you ask me, two major things, viral hepatitis and this fatty liver disease.
You're right. So next question again from you. In the Pakistan prospect, we have seen the NAFLD has shifted into MESLD. How it is relevant in Pakistan, because we have the highest percentage of the diabetics, and metabolic syndrome is, after US, it may be we are going to lead this MESLD sort of things. What do you see? How do you see your patients? In Pakistan, MESLD is relevant?
Absolutely. I just give you one liner. You do not treat the organ, you treat the patient. That's it. So when it comes in a spectrum of disease, you have to have the holistic approach.
Yeah.
So it's not the liver we are treating. There are lots and other things that are happening with the liver. And I think you cannot ignore those.
And the majority of the mortality in MESLD is related to cardiovascular diseases.
Well, it depends which dominates. I mean, if you take at the core obesity, you have cardiovascular risk factors, you have kidney disease, diabetes, fatty liver. I mean, it all depends where if somebody has impaired liver function test and there is no other cause for that impaired liver function, I think the liver mortality will
be high.
Notches up.
So it depends on patient-to-patient basis.
Yeah, that's the job of the physician to evaluate. And I think this is something where multidisciplinary approach comes in, where joint clinics come in. But at the same time, we don't have the luxury of such resources. And that's where we have to train our clinicians to understand the subject. I would say triage the patient. So what is, you have
scores
Who is
more
now.
serious?
I mean,
Who is more serious? Sir, what is the future of pharmacological therapies in fibrosis related to metabolic syndrome, MASH related?
I think we need to be careful that we don't get dominated by the drug companies here.
Yeah.
And there's a lot of money to be made in offering treatments for fatty liver disease. But as Asad says, we need to treat the patients.
Yeah.
And the first thing to do for the patients is to help with their diet and their exercise. Let's do the basics first. Let's make people eat healthy food, eat less food, and move more. And then we won't need the drug. We can't drug our way out of this disease because it's a lifelong.
Yeah.
We can't give people weight-reducing drugs for 10, 15, 20, 30 years. So we can't treat our way out of the obesity crisis. We have to tame people, educate people. There will be a role for pharmacology. There will be patients who cannot lose weight, who cannot exercise sufficiently. And for those, there are emerging treatments, mainly directed towards the underlying metabolic problems. Society drugs that are starting to make people feel full when they've eaten are the new fad. We've seen a few drugs licensed that will increase metabolism and burn away the fat. But if you think about that for a moment and say, are we really going to give 30% of the people in Pakistan an injection for the next 10, 15 years? This is a crazy talk. So let's do the simple things. Let's look at our patient. Let's get them to move more, eat less, and save the expensive drugs for the few people who really need them.
So exercise and diet is more important than the drugs. Drugs have a role, but in few number of patients.
Absolutely. If you can lose 10% of your body weight, most of your fatty liver will disappear. So the first thing to do is eat less, move more.
Sir, how do you see the relation of diabetes with MESLD? How many patients of MESLD have diabetes in your clinical practice?
Well, if you do an ultrasound in a diabetic, it's a universal thing to have a fatty liver reported on ultrasound.
Yeah.
So that's where we actually need to be careful. That's where the concept comes in. How do you risk assess these patients? You know, I mean, it's not the diabetes, so you have to look at the LFTs. But the thing is, as Graham mentioned, weight loss you achieve with the universal things, diet and exercise, and we can be choosy in choosing, the diabetes treatment, which will help in weight loss also. And all sorts of guidelines now, they are promoting a lot of drugs which are helping weight loss. GLP-1 analogs are one thing which are now come up very high in the list of initial treatment of diabetes.
So weight loss leading to resolution of diabetes and fatty liver.
Well, everything will, again, if obesity shrinks, you lose obesity, all the risk factors come down. That's healthy life and you live longer. But the bottom line is weight loss. It's all the means how to achieve the target. You achieve getting close to the ideal BMI that you are trying, to get close to, and that's where. But the problem is that people have to understand there's no quick fix. They have to learn the basics. If you have a semaglutide injection, you don't rely on one treatment to do the work. You have to do something. I mean,
you have to put your effort too.
Yeah, absolutely.
I've seen the people saying, Dr. Saab, you're giving the injection, but we are taking a lot of food. This is how.
But you can't do that. Yeah. You can't ask for loans from the world and then say we don't have our own resources. It's not like that. You don't rely on a drug. So something has to come within. There will be people who will really need help, whether in terms of medicine therapy or in terms of bariatric surgery, but there will be people. But again, majority of the people, they have to be told that, look, this is what we need to do. And then what will happen? You stop semaglutide. You regain the weight. You can't rely totally on a drug.
So this should be used very in selective number of patients.
Yes,
and after counseling.
After counseling, and again, what I would say, when I'm repeatedly talking about triaging or risk stratifying the patient, because there will be people who will fall in the zone. Let's say I take example of liver, where the liver damage can be much more rapid. But then I won't be relying on. Maybe I give them 3 months, but I won't be relying on, because I have to intervene. I don't want them to end up with a lot of fibrosis in the liver where I can't reverse the things. So that's
so we need to see the patient. We discuss a lot about the obesity with fatty liver and fatty liver with diabetes. What about the lean mass? Have you seen the patient who are not obese, but they have fatty liver and inflammation in the liver?
They're very difficult, because it's very hard to convince someone that they have lean mass. I have a marathon runner who has a biopsy showing fatty liver disease. And I said, you probably need to do more exercise. And he looked at me. And I thought, he's doing more exercise than I am. So it's a real thing. I think it's a fascinating phenomenon, and I don't think we understand the metabolism. I think
marathon runner had fatty liver.
Fatty liver disease, significant scarring. I gave him metformin because I was running out of options here.
So we don't have not a lot of options for fatty liver in lean MASH.
Lean MASH is the understudied part of fatty liver disease because it's quite rare. Most of 95% of my patients have obesity and diabetes and metabolic syndromes, but there is a little cohort of people. There are some odd conditions. Some of the lipodystrophies store fat in their liver. Okay. So there are some clues.
Genetic problems.
Genetic problems do so, and cystic fibrosis, of course, causes very significant lean MASH. And I think those are the diseases where we probably need to do more metabolic studies. But we haven't yet got an answer to lean MASH.
So it's still a mystery.
It is a mystery, but if I was a youngster going into MASH research right now,
so genetic factors.
That's where I'd go, because the obesity-related MASH is very popular. That's where the drug companies are looking. But there's another spectrum out there we need to just be aware of.
There is another category I want to learn as a hepatologist. In subcontinent, we have people who are not looking obese, but their percentage of fat in the body is higher. I think this is a third category, although their BMI is not very high, but the percentage of fat is more than the normal.
You're absolutely right. There is definitely a different BMI distribution in people in different geographies. Okay. And certainly we tend to focus on the affluent countries. The Americans pay most for the drugs, so that's where the research does. But there are different categories of disease, and we may need to do special studies in Pakistan. And I think my message to the young people of Pakistan would be, ignore what the Americans are doing. They talk rubbish anyway. Do what you need to do locally. Find what is your fatty liver disease and find your best strategies for treatment, because they're going to be different.
So the local guidelines should be, published and should be advocated.
Very important that Pakistan doesn't just follow, and Pakistan leads. You have your own problems, you have your own people. Go and find out what's causing your problems and fix it in Pakistan. You have the people to do it, you have the brains, so don't just follow, do some leading. This
is a very beautiful message. Sir, I'm going to continue this question with you. PSH, as the president of PSH, we collect a lot of data from the recent articles. We have a lot of. What is your future strategy to formulate this data into guidelines, or what should we do?
Actually, we are already started to work on some guidelines in local perspective, and that's going to be very important. We have done it in hepatitis C because the patients we get, what sort of training in the primary care level we have, and then the reach of what I would say the specialist doctors in various in various areas of Pakistan, and which is very uneven distribution. But even then, bigger cities they have more resources. They are much more closer to the international guidelines. But as you move away from the bigger cities, things start to change. So that's where the role of Pakistan Society of Hepatology come in. And guidelines sometimes become too strict a word. Guidance is another word that we use to guide people. And we are holding regional seminars to tell people. And the first thing is to, the first and foremost before we really jump into the treatment is to identify the at-risk patient. Yeah. This is important. I mean, you will have 100 patients with fatty liver, but you may have to focus more on 10 of those. And that's where a lot of things come in. Maybe a 30 or 40 just need some lifestyle change or something, where you can possibly wait and see how they do with, say, 3%, 5% of body weight reduction. So that's where we want. The only issue that we have in Pakistan is because a good quality research data requires funds. And sometimes we are not able to generate enough funds to hold that study.
So assessment, early risk assessment of the patient is important, and change in the mindset to take the research into the concept and the future prospects.
And this costs nothing.
You're right. Sir, what about hepatocellular carcinoma in the patient with muscle-associated cirrhosis?
The biggest problem facing Pakistan in the next few years is going to be associated cancers. And liver cancers from hepatitis C that we've cured are far too common. Liver cancers being driven by diabetes and hepatitis are very common indeed. So I think the challenge will be, how do you manage people with high risk for liver cancer? In England, we have the resources. We do ultrasound scans every 6 months. We do alpha-fetoproteins. We do transplants. We resect. You don't have the resources to do that to the population at risk. So I think we need to change our approach in Pakistan. I think we need to start looking at doing local trials of preventative strategies. There are some interesting studies with metformin and aspirin as potential preventative agents. We need
in the fatty liver?
In fatty liver disease. They're small-scale studies.
Okay.
We need to look at large scale in Pakistan to see, are there ways that we can reduce the incidence
of hepatocellular carcinoma just with metformin and aspirin?
They would do that. That would be my trial, but it's got to be large scale. You want a large group of at-risk people and see what the numbers are, because we have to reduce the incidence. And then you have to think about oral treatments. We can't give everyone resection and radiofrequency ablation. So we need to change our mindset and, again, stop following the Americans, start getting your own local treatments, your own approaches to this, because you cannot operate your way, you cannot ultrasound and scan everyone at risk in Pakistan. So I'm afraid you're going to have to think laterally.
Yeah.
But this is an opportunity.
So this can be the major risk in the future.
I think that, for me, if I was starting out in Pakistan right now, when people come to me and talk about research, I say, don't worry about Hep C, it's done.
Yeah, it's done.
But liver cancer, post-hepatitis C, that's the challenge.
Yeah, you're right. Liver has cirrhosis. Sir, the last question is, what is your mission, from the PSH point of view and hepatology point of view, what is your roadmap?
If I have the powers, if you ask me one wish, I just want to eliminate hepatitis C from Pakistan.
So you are working on it.
I mean, there's a lot of talk. There's a lot of, people talk in the government, in private circles, in the pharmaceutical industry. I tell you, We have still a lot to cover.
Yeah.
There's still a lot to cover. And other thing is my focus, and which I have actually tried as my stint as president, is to make people aware, because we have excellent drugs which achieve cure in hepatitis C, to identify the at-risk patient for liver cancer. This is extremely important, because if you don't do it now, 3 to 5 years down the road, somebody will come up with a huge mass in the liver. So we have to sensitize doctors. Please do the relevant screening every 3 to 6 months, whatever the situation is. And if you pick up anything, you must know the centers where to refer, where they can be worked up further. The earlier you pick, the better the prognosis is, and possibly cure even.
Yeah. So earlier you pick, the better the prognosis is. Sir, final message for us.
Stop talking about clearing Hep C. Go do it. You know how to do it. You have the people to do it. Just do it.
Okay. Thank you so much. This is from the podcast. If you have any question, you can ask in the comment. And I am very thankful to my guest. Allah Hafiz.